Okay, thanks everyone for coming. I'm Joe Calderoni from Mount Sinai South Nassau Hospital, which is a teaching hospital, a regional medical center on the south shore of Nassau County, 455 beds. This is our 24th Truth in Medicine public health poll. It's the only hospital-based public health poll that we're aware of in the New York metro area. And you might legitimately ask, why does a hospital do a public health poll? And the reason for that is pretty easy and clear. First of all, we have great leadership at our hospital. Dr. Sharma, give a wave. Dr. Sharma is the president of our hospital. He's trained as an emergency medicine physician. Dr. Glatt, give a wave, the chair of our Department of Medicine, also chief of infectious diseases. Both Dr. Sharma and Dr. Glatt were with us, led us through the COVID pandemic. They are dedicated to public health topics and to trying to make sure that the public is informed when there is a public health crisis, and just day to day how folks in our service area can improve their health. So they've been big supporters of the Truth in Medicine poll, and we're very delighted to have them with us here today, along with our other panelists. And our other panelists include Mike Talley, I hope I got that right, Kamdar, she's the Senior VP for Aon, give a wave, right, very good. Chris Clark, he's the Senior VP for Optimum, and Brian Leedy of Island Harvest. Very good. So we're going to have a good discussion today on the poll results, and I want to introduce Dana Sandeman, my colleague, who's going to go over that. But before I do that, I got to thank Four Leaf. Anyone here from Four Leaf today? Thank you very much. This poll does not happen. Does not happen with our friends from Four Leaf from the very beginning. And again, we started this in 2017 was the first poll we did. They stepped right up. They saw the value of it, and they have been funding the poll ever since. And we do hire an outside national polling company to conduct the poll. We don't conduct the poll ourselves, so that we make sure that we adhere to proper polling practices. So again, thanks to Four Leaf, and also thanks to Optimum. Dave is here. Dave Widmer, Dave and his cheering section back there. Thanks, Dave. So Optimum has given us this terrific space to have this discussion. We're very grateful to them for their partnership as well. And so now I turn it over to Dana, who's going to review the actual poll results, and then we're going to have a panel discussion.
Thank you. Thank you again to Four Leaf and Optimum for co-hosting this event with us. So as Joe mentioned, we conducted this poll back in July. LJR Custom Strategies conducted the poll. 600 metro area residents responded to the poll. So that's metro area, the 5 boroughs of New York City, and Long Island. It was conducted via cell phone and landline. 3.9% is the sampling error. So some of the key findings I'll just review, and then we can go into them a little bit more specifically. But a plurality of residents think that the United States is unprepared for a public health crisis. And just keep in mind that this was done back in July, so more than 2 months ago. 40% think the country is prepared, and 17% are not sure. And most importantly, respondents were concerned about the emergence or re-emergence of infectious diseases. 80% about the flu, 77% about measles, 75% about bird flu, and 65% about the new strand of COVID. And you can see here on the chart how that breaks down. Very concerned would be the bright red. We also wanted to ask about health insurance and how concerned respondents were about paying for health insurance, accessing health insurance, and whether or not the insurance that they receive was adequate enough for their family. 8% said they do not have health insurance. 36% have private insurance. 17% are covered through the Affordable Care Act, and 25% were covered by Medicare or Medicaid. So just you have an idea now of the population we were polling. Overall satisfaction with health insurance for those who had it was quite high. 27% said they were very satisfied, 53% were satisfied. We also asked about your prescription drug coverage, and that satisfaction was also very high. 76% were very satisfied. And among that 8% who did not have health insurance, we went a little bit deeper into why they might not have health insurance, and 49% said it was because it was too expensive. 26% said their employer did not provide it. 15% said they did not need it, and 6% said they did not know how to get health insurance. And overall, I think this is an important point. 67% strongly agree that they're concerned about being able to afford health care for their family. You can see there on the pie chart. So again, when we talk about the public health crisis, a plurality of residents do not think the United States is prepared. And they do believe that the government should help people access affordable health care. So these are some of the key messages that we're going to have our panel dig a little bit deeper into.
Dana, could you go back to the pie chart?
Sure.
Talk about how people are satisfied with their health?
Sure. So you can see 53% satisfied, 27% very satisfied, and then the 9% very dissatisfied or dissatisfied. Just a few other key findings that I'll quickly go over. So the younger population without insurance, so again, in that 8%, expressed concerns about affording health insurance. They do believe the government should help provide health care, but they're not highly concerned about infectious diseases. Those with private insurance are obviously the ones that are highly satisfied with their coverage and their prescription drug coverage. And we'll put this up a little bit later at the end of the panel, but if you or someone you know is having difficulty accessing health insurance, this is the information on how to contact the New York State Department of Health. Now I'll turn it over to Joe to start the panel.
Thank you, Dana. I hope this mic is working. Can you hear me okay? Very good. Dr. Glad, I'm going to open up with you. So we heard in the poll results, those who responded, in the 70s, more than 70% for each one of these, people are worried about the measles, they're worried about the bird flu, and they're worried about the next strain of COVID. There's also a lot of confusion out there about vaccines coming from the federal government and whether vaccines, whether we should get them or not. We've seen at least one state, Florida, is talking about removing the mandatory requirements for some vaccines. What are we to do?
So I only have 3 minutes to answer that question, which would really take several hours to really go into the depths of explaining why I'm going to say what I'm going to say. But vaccines remain an extremely valuable tool, possibly the single most important valuable tool to eliminate certain diseases from society. Now, the only illness we've ever gotten rid of is smallpox. And the only reason we stopped this mega killer, it killed hundreds of millions of people, was through vaccination. And we have almost eradicated polio, but we're losing ground. And in the United States, we had come very close to eradicating measles, and we're losing ground. And it is very important for people to realize that you need a herd immunity for some of these illnesses to really go away. And there are some people that unfortunately cannot take the vaccines for various reasons, medical contraindications to taking the vaccine. And therefore, it is very important that the more people that can get vaccinated for these highly contagious diseases like measles. Measles is probably the single most contagious disease that we have. I don't want to scare anybody, I don't have measles, but if I did have measles right now and you weren't vaccinated, almost everybody in this room would catch measles, even though we're not right next to each other. It's highly contagious. It can be prevented. There's no reason for anybody to die from measles. It is an essentially preventable disease. And yet, unfortunately, we've seen in the United States this year 3 people dying from measles. Worldwide, there are hundreds of thousands of people dying from measles, a truly preventable disease. So it's very important for people to realize that when you're talking about measles vaccination, it's different than talking about yellow fever vaccination, which isn't indicated for anybody in this room most likely. So vaccines need to be looked at individually, not overall as, yes, I'm in favor of vaccines, no, I'm against vaccines. Every person needs to decide, is this vaccine appropriate for me or is it not appropriate for me? And that decision should be made by correct medical information, discussions with your physician to decide, yes, for me it's good. I look around the room, I don't see any old people. But if you're above 75, if you have underlying conditions, then the RSV vaccine becomes very important for you. COVID vaccination is very important for some populations, less important, still possibly very helpful, but much less important for other populations. Flu is something that everybody's at risk for. Young children can get a very, very bad reaction from flu, can cause death, can cause paralysis, can cause all sorts of medical troubles. So influenza vaccination, flu vaccination is something that everybody should consider and is an extremely important vaccine. There's other vaccines that are dependent upon your age. Shingles vaccine is a great vaccine for the appropriate person. Pneumococcal vaccination to prevent pneumococcal disease is very appropriate for many people. So each person really needs to sit down with their physician and say, hey, what's good for my health? What do I need? And if they have questions or concerns about these vaccinations, they should be addressed in a polite, amicable atmosphere. It shouldn't be fighting. We have too much fighting going on. It should be education. The appropriate things that we know should be said, and the things that we don't know should be said. And sometimes it's best guess. But this is the way that we can keep America healthy, and this is the way that we can truly improve the health of our community, which is the goal of this poll and the goal of all the people at the hospital.
So stay off social media and talk to your physician. I think that's what I heard. Dr. Sharma, I got one for you, coming off of what Dr. Glatt just said. Dr. Glatt used the phrase, which I'm not sure the public really understands. I'm not sure I really understand it. Herd immunity. Would you just, that's a softball question, I hope, for you. Go ahead.
Sure, the concept's pretty straightforward. If you vaccinate enough of the population, the disease doesn't have a group to spread to. Once the disease stops spreading, that disease is gone. So a good example, Dr. Glatt mentioned measles. We did such a great job of vaccinating against measles, we really didn't see measles in this country. Now, the vaccine isn't 100% effective, meaning you could still get measles even if you're vaccinated. But since there was no measles around, you didn't see measles. And I think that's part of the challenge, that people's expectation of a vaccine was that you didn't get disease. That's not the case at all. Vaccines reduce the likelihood of getting disease. They reduce the likelihood of severity of disease. And they also certainly, what we've seen is reduce the likelihood of hospitalization and death from a disease. So when we vaccinate people for herd immunity, the goal is then not only to protect those who are vaccinated, but as Dr. Glatt mentioned, there's a handful of people who can't get vaccinated. The very young aren't able to get vaccines until they get to a certain age for certain vaccine regimens. So they're protected also. And then as you get older, and we said there's no old people in our audience today, but those vaccines you got when you're younger, they start to fade. So they're at risk also, and herd immunity protects all of those people. So they protect our newborns, they protect our grandparents, and they protect those who can't get vaccines.
So it's not just for cattle, it's people. People need herd immunity. Very good. Dana, I'm throwing it to you.
Yeah, I think we should go back. We'll come back to infectious diseases, but let's focus a little bit more on the findings of healthcare. So, Dr. Sharma, as you saw, 8% of the population reported they do not have health insurance. What happens? Talk to us a little bit about what happens when an uninsured person does not needs access to healthcare, and how do we work with those people in the hospital setting?
Sure. Just one sentence before that, for some foundation, right? When we talk about developed nations, and the United States being the leader in developed nations, it has to do with so many basic things that are needed for a good lifestyle. There's foundational stuff like highways and schools and hospitals, but also simple things: clean drinking water, stable food supply, stable economy, access to good health care. So all of those are required to really be a developing nation. As we reduce access to health care, it starts to chip away at our ability to really take care of the population at large. When folks don't have insurance, what they end up doing is they do one of three things. Either they don't get care at all, which can result in very bad outcomes for them. They delay care, which results in worse outcomes than they would have had they had access to care earlier, or they seek care in a safety net place, such as the emergency department. And any of you who ever going to have to go into an emergency department, you know they're busy, busy places. Population in the U.S. is roughly 340 million. Last year, there were about 140 million ED visits. So you can imagine practically 1 out of every 3 Americans went to an emergency department last year. As a result, it's an extremely busy place where you're there for emergencies, but when folks don't have access to healthcare, they come for what would be an office-based visit because they have no other choice. Emergency departments under federal law are required to treat any patient regardless of their ability to pay, and patients can go there as a safe harbor. It's good that we have that safety net, but that safety net can only bear so much strain before it breaks. And then what happens to the real emergencies that are coming in, and how do they get treated in a timely fashion to prevent that emergency from becoming a true crisis of health?
Thank you. Just to follow up on that, Dr. Sharma, what role can hospitals play in screening and other no-cost programs? I know at Mount Sinai South Nassau, we were saying yesterday, we do a no-cost mammography every October for those who do not have access to health care. What other ways roles do we play in ensuring access to health care?
That's a great question. So we talked about those who get sick and don't have access to health care, but the reality is health care is an ongoing phenomenon. You heard in the population of the 8% that don't have insurance, some folks said they didn't feel like they needed it, about 15%. And they were younger folks that are healthy and don't feel like they need health insurance. Reality is you should monitor your health no matter what your age is, because that's how you find problems that are otherwise undetectable. High blood pressure is a great example of a disease state that causes multiple complications, but is undetectable. And so South Nassau, as well as many other health systems, provide health fairs. And actually, Dana oversees all of our community outreach programs. And they'll go to the boardwalk at Long Beach, or they'll go to senior centers, or they'll go to schools, and they'll try to promote health screening. So we can check for blood pressures. We can check for blood sugar to see if somebody has diabetes that they're unaware of. We've done prostate screening exams. We've done skin exams for skin cancer and all of those things. Hospitals can definitely promote health through these outreach programs, partnering with community groups to help provide education and information, and certainly giving access to at least the minimal screening examination, so that if someone is detected with the disease, they can at least try to get treatment as early in that disease course as possible, as opposed to, again, waiting for a longer period and having a worse outcome.
So for those who do have insurance, Matali, good news for you. 80% were satisfied with their health insurance coverage and 67% with their prescription drug coverage. However, healthcare is expensive. So can you talk to us a little bit about what the factors are contributing to this increased cost?
Yeah, and this is a question we get a lot. So I am part of Aon Consulting, and Aon just recently, within the past week, actually really good timing, published a projection on employer premium increases. And so for 2026, the expected employer increase is 9.5%. And this makes it, I think, a third year in a row where it's like almost double-digit trend increase. So yes, it is, affordability is an issue. What's driving these large trends? So I think we all experience inflation in the grocery store, in our everyday world. So do providers, hospital systems. So does the whole healthcare system, right? So there's inflation, which is supply chain increases. There's inflation in labor costs, and all of that translates into this higher trend that we're seeing, that we are experiencing in healthcare. Another big reason is, it's a good one, but also on the flip side, it's costing a lot, is the advent of new drugs. GLP-1s, I think we kind of hear that all around. We see the ads, like GLP-1 drugs, gene therapies, exorbitant prices, like millions of dollars for a gene therapy to make people's lives better, but it costs a lot to do these things. And then the third aspect, I would say, is in terms of the relating it back to the kind of new technologies and things coming out, we do see a rise in chronic conditions and treatments and utilization, right? So people are using care more, which adds to the cost in the system and the burden. So I would say those are kind of the primary drivers of the healthcare increases that we're seeing.
So 26% of those who do not have health insurance said it was because their employer did not provide it. So in your experience, why might an employer not cover health insurance?
So I would say it depends on the type of employer. I think the Kaiser Family Foundation has some statistics that 54% of Americans get insured through work. Large employers primarily will cover most, if not all, their people under the employer-sponsored health plan, what we call the employer-sponsored health plan. When you get to smaller companies, 50 or less, it becomes less likely. It's actually way less likely that you get insurance through your work when you're working for a much smaller company. The other big thing to understand is eligibility is a word we throw around a lot in my space. And so what does that mean? So you're a part-time worker who doesn't meet a criteria. You have work, but you don't work enough to meet criteria to get health insurance through your employer. You're a seasonal worker. Maybe you don't meet the criteria. You're a contractor. Maybe you don't meet the criteria. There's also something which is a waiting period. It can be up to 90 days to be eligible for your plan. Even if you will meet the criteria at some point, you might not meet it right now. And so all those factors can lead to someone saying, I don't get insurance through my work. It may be temporary. It could be the type of worker you are, but those are various reasons.
Thank you. Chris, on to you as the Senior VP of Compensation at Optimum. So what Mitali said about the increasing cost of health insurance. Talk to us a little bit about what you guys are seeing with the increased cost of health insurance, and then also on the flip side, what your employees are looking for in a healthcare plan.
Sure, absolutely. So at Optimum, we are not unique in any way. We are experiencing a significant increase in our health plan costs, just like all the companies that were included in the survey that Aon ran. This year, we've seen a huge increase in high-cost claims. So high-cost claim is any claim above $50,000. So we're seeing a tremendously large increase in the number of high-cost claims associated with certain chronic conditions, cancer, musculoskeletal, as well as cardiovascular disease. What's also driving our cost is the GLP-1 drug utilization. We're seeing a lot of folks that are using it for weight loss, which is great to help people lose weight, but there is a cost to the plan associated with that higher utilization. With regards to what employees seek, I think it's so important as a plan sponsor to solicit from your employees feedback on what are their needs, right? We're operating a plan and we're not sure exactly, what individuals need. So it's so important to reach out to employees to understand what they're seeking. I would say in its simplest form, employees are looking for high quality, affordable health care, and they're looking for choice, right? One size does not fit all. It's hard just to offer one single plan. We, alongside many other larger employers, typically offer multiple plans. So we'll offer, maybe a plan that has in-network access only, or a plan that provides for in-network access and out-of-network access. And you may have a plan that is a high-deductible health plan with a health savings account that has lower premiums, because everyone's medical needs are different. So we want to ensure that we provide choice. We also see choice in the number of carriers or medical carriers that employees can choose from. Here at Optimum, we provide our employees with 2 medical carriers as well as 3 networks. There's 2 broad networks as well as a narrow network. So if an employee wants to save a bit on their contributions, they could select a narrow, high-quality network of providers. We're also seeing a lot of interest from our employees in assistance with family forming benefits. So we've offered here at Optimum, and other companies do as well, assistance with IVF, company-paid IVF, or surrogacy, or fertility assistance programs. Finally, I would note that we all know utilizing the healthcare system in this country is not easy, right? Sometimes we get explanation of benefits, really doesn't clear to us. Sometimes we might need help finding a provider. So many organizations, including Optimum, partner with third parties that provide that specialty support. So it's available to all employees and dependents so that they could reach out and get some assistance in helping to navigate the healthcare system.
Thanks, Chris. I don't know if anyone else wants to chime in. I think that's an important topic. If there's anything companies are doing to kind of meet the needs of their employees. I don't know, Vitaly, if you hear anything anecdotally even from companies.
Yeah, I do think, going back to this theme of education and what should we be doing, I think absolutely, conversation between a physician and their patient, but employers are educating their people more and more, maybe bringing in experts like Dr. Glatt to just talk to the population directly so that they can get their questions answered about what they should be doing and is best for their health outcomes. I also think that accessibility is a big one, meaning mammogram vans or vaccine vans, or just bringing those on site, bringing those to people, I think is helping the population at large just get that. And then, policies become important. I know we're talking about healthcare, but policies and healthcare are pretty closely related, meaning, are you making it flexible enough for your people to go get preventive care before they have to end up in the emergency room that you were talking about, right? So making sure that your policies support getting those vaccine appointments in, getting the annual healthcare checkup in, so cancers and other things can be caught earlier, I think becomes very important.
So the Mount Sinai Health System does one other thing to improve access to healthcare, because affordability is a problem for employees. They have a salary banding model. I'm curious, does Optum have that too?
Yes, we do have a salary banding. So part of our benefit philosophy is to subsidize the medical contributions for our lower paid employees. So we have 5 salary bands. So our lower paid employees pay a much lower percentage of the health plan cost as compared to our higher paid employees.
So to that point, Brian, I know Brian's here from Island Harvest, talking a little bit about the 6% of those surveyed who do not know how to obtain health insurance. So I think organizations like yours play a key role in assisting in accessing healthcare and other services. Can you talk to us a little bit about that?
Absolutely. Hi, everyone. Island Harvest Food Bank is the leading hunger relief organization on Long Island, servicing many of your neighbors. Our mission is to reduce food waste and hunger. And simply put, we don't want any of our neighbors in our community to wonder or worry about where their next meal is coming from. And we really see healthcare, food insecurity is going hand in hand. If you're not having health insurance, you're pretty much most likely food insecure in some way. We look at the world that we live in, and Long Island's incredibly costly to live in. The Alice report, which is United Way dollars, shows that survival budget's $137,000 for a family of 4, just to meet basic needs of housing, childcare, food, medicine, all those things. We know that that's a decent salary most places you live in the country, but here you're on the edge of affordability. And the poverty rate's $32,000 on Long Island for a family of 4. It's 4 times less than that survival budget. And the gap, many of individuals on the poverty rate qualify for Medicaid, but there's that gap of the working poor, the working poverty individuals that are working hard every day, 2 dual income salaries, but are not making it and having trouble. And we see them come to us for assistance throughout every month, every day, to come for food. So we're working hard to combat that. There's other issues. Younger population, especially, don't feel they need health insurance. They're invincible, right? But it usually means they can't afford it, even though they say they don't need it. But it's a challenge because a lot of, especially those that are challenged economically, are with conditions like diabetes and long-term issues that are going untreated then, because they're not even being, acknowledged or found out. It was touched on about healthcare being confusing. It's navigating healthcare for all of us. I know it gets crazy. We got different plans, and let me tell you, when you're worried about feeding your family and other things, trying to navigate the system is very difficult. We have a community empowerment program, which is basically our social workers that help individuals navigate. Number one, our mission is SNAP. So we want people to apply for SNAP because that gives them food. But we then triage all their other challenges, because usually if you have food insecurity, you're having housing issues, you're having healthcare issues. So we look at it holistic in that way to help people solve their challenges and refer them off to the proper agencies and make sure we're getting them help. I think more to say, but I think that
All right,
captures.
while we're on safety net issues, I got a follow-up for Dr. Sharma. You mentioned emergency rooms are busy places. They're already under pressure. 1 in 3, I think you said, Americans have visited an emergency room. By the way, if anyone's seen the Pit, that show gives me a headache just watching that show. It's but they won a lot of Emmys. The big beautiful bill, which Congress passed and the president signed, it seems like the consensus is fewer people are going to be on Medicaid, which is largest, one of the largest government insurance programs for economically disadvantaged folks. Are hospitals getting ready for that impact?
So hospitals will have to start to prepare. It's unclear what the impact will be in the end. As we know, the budget is due at the end of the month for the federal budget. They'll either need a continuing resolution or an approved budget, which I can't imagine there'll be an approved budget. So the continuing resolution will be an opportunity for both parties to get together and try to address some of the gaps in H.R. 1 that would create large pitfalls for health insurance. Just as an example, in New York State, the way H.R. 1 is written today, it would disenfranchise about 1.7 million New Yorkers from access to expanded Medicaid. Now, the state would also have an opportunity to step up and fill the gap as well. So I think right now hospitals are in a wait-and-see mode to see what actually will become of all of these legislative efforts, as well as financial jockeying that the state may be able to do. But ultimately, we do need to prepare for that type of a phenomenon where X number of people who previously had health insurance don't have health insurance, and how do you make sure they still have access to care and don't rely solely on the emergency department for care?
I mean, under law, we're not allowed to turn anyone away from an emergency department.
Correct. But it is, the law is specific in that we have to provide stabilizing care. So for the average person, that may only be one visit, and then they may have a chronic problem that they need to deal with, that they still need access to care, that the emergency department is never going to be able to meet that need.
Dr. Glad, any thoughts on that as the head of the Department of Medicine?
Sure. So we're seeing, unfortunately, many people that either can't afford their medications, can't take the preferred medication, have to take an alternative medication, or that they're not even seeking health care because their copays or sometimes the deductibles are too high. Many people have been taking plans that have a very high deductible, so they're insured for what we call catastrophic events, but they're laying out the first $5,000, $10,000, $15,000 of their health care from their own pocket. And as a result, many people where finances are tough are saying, well, I really don't need that, but they really do need that. And ideally, everybody should be able to afford. We have to figure out a way that everybody can afford the basic health care to provide people of different ranges of income that they can get the essentials, the really necessary health care. Not everybody needs to have every single drug available to them, but the medications, the preventative medications, the screening, the imaging studies or screening tests that will prevent much more expensive and, of course, catastrophic illness for those patients. We have to figure out a way that we can do that well, because it's much less expensive to give good medical care than it is to provide bad medical care or care that's already far down the line.
Dr. Sharma's got an additional point. By the way, we will have some time for questions, so put your question hats on and don't hesitate.
I just want to explain one concept that the American healthcare system is based on. It's called cost shifting. So the government pays for X amount of healthcare, but they always pay less than the cost of healthcare. So on Medicare, the average reimbursement is around 90 cents on the dollar, and on Medicaid, it's around 68 to 70 cents on the dollar. So what hospitals and other healthcare organizations have done is they've shifted that cost, that delta, to private insurance. So you've heard the 9% increases, and then employers are bearing the brunt of that, and so they've shifted the cost to their employees. And that's either through banding systems, which help some get access, but also charge those who make more, or high deductible plans, or other structures that are really put the onus on the employee or the patient. The more that we remove these safety net programs like Medicaid, the more cost shifting will happen in the healthcare space, which only drives premiums higher and higher. And at some point, it'll be a breaking point. Either the hospitals will close, or healthcare systems will go defunct, or employers won't be able to meet the needs of their employees and will shift a significant percentage of costs to their employees, which have the same effect as not giving them healthcare. So it is a dangerous game that's being played right now with regards to the healthcare changes. And rather than what would be beneficial is if we saw a glide path as opposed to a rapid removal. This would allow for some shift and some evolution in the healthcare space, because healthcare costs are too high. There's no argument about that. We spend way too much money in this country on healthcare. We need to do a better job of being efficient with that. But that doesn't happen overnight. It takes time to build the programs that will allow us to do that, and that would be a better model than what is being what's seen as a more drastic approach.
And this is timely, Dr. Sharma, because I think many companies like ours are going into open enrollment period. So I don't know if our healthcare experts want to speak a little bit about predictions for the next 6 months of how insurance or employers are looking to shape healthcare plans.
So I'll start, and maybe Chris, you can chime in. So I would say managing plans efficiently is like at the top of everyone's mind. I think there is honestly, I sit in conversations all day long with employers about costs and how to control costs. And the last thing they want to do is shift more to their people, because they know that everyone's getting hit on every side. And so the conversations, it's actually refreshing. The conversations that are had in those rooms is more about how do we contain costs without impacting our people adversely? Like, that is the biggest question we get. And so it's about managing the programs you offer, managing health more appropriately, managing it efficiently. Are we investing in the right things that we're offering our people that make a difference? Do our people take advantage and use those things? So, there's that. That is like the biggest element we talk about. We talk about network management, contracting management, the carrier pricing, negotiate with the carriers to bring down costs. Can we put a cap on our large claim liability by insuring that separately? Those are the kinds of conversations that are being had. And then as a last resort, it's okay, well, we need to do something because we have to make sure the company stays on track. So maybe we shift costs and contributions and design. But even with that, employers take a majority of the cost. They take the burden of about 80%, I would say, of the cost is on the employer.
Yeah, I would echo with what Mitali says. We work with our consultants, meet with them, continuously throughout the year, where we monitor our expenses and figure out how can we best manage expenses for future years as well. The cost increases are unsustainable, right? I think if we look at what inflation has averaged over the last 10 years, it's like 3%. And if you look at medical inflation, it's like 6% after plan design changes. So we're all hearing that it's unsustainable, but every year it seems to be going up and up and up. So something needs to happen, and I do hope that it's a glide path to get us to more sustainable costs. Similar to the clients that Mitali works with, we here at Optimum look to absorb the vast majority of costs, right? So we look to ensure that we're getting the most efficient networks, the best pricing possible. We haven't increased our deductibles. I think it's been 5 or 6 years. So we've been absorbing that cost increase every single year. We do pass on along a modest increase in medical plan contributions. We're still in the process of figuring out our designs for next year. But the goal is to, once again, try to absorb as much cost as possible.
At Mount Sinai South Nassau, as a healthcare organization, obviously healthcare access is extremely important to us. We can't have employees not have healthcare access. It's part of our fabric. And we've been able to maintain our costs flat for the last 7 years in terms of what the employee pays. Obviously, our costs have been going up year over year as healthcare has gotten more expensive. But our commitment is that our employees shouldn't have to bear that brunt. And we've been able to do it, fortunately, but it does get more challenging each year. And in the last few years, healthcare inflation has been around 11%. So we've seen huge spikes in the cost of healthcare, and we've kept our payroll deductibles and out-of-pockets flat for the last 7 years.
Do you have any questions from the audience? Anyone? Anyone at all? Oh, we got one in the back. Dave.
No microphone, just.
Yeah, I'll repeat what I say.
It's okay. As an employee of Optimum, I can speak firsthand on the fact that while we're also very customer focused and customer first. I also think, Chris, at least I feel that we're also employee first. And I'm not patronizing you. I do see that. Doc, you mentioned unsustainability of healthcare costs. And interestingly enough, my son is now married, at least formally, we're having a wedding next summer, to a young lady from the Netherlands. And the idea of socializing healthcare, because it's very privatized here in the United States, at least from what she can see, and the affordability of it is not equal to everybody. Not everybody has access to healthcare. What is really keeping, and we've been hearing, my entire life, I've been hearing about accessibility to healthcare, affordability of healthcare. It just keeps going up. We hear crazy stories about insane costs of certain things like cotton balls or whatever. Like it's almost like a NASA, where a toilet seat costs $10,000. I don't want to get off the track here, but what is it that's preventing us to kind of come up with some sort of, to use to Chris's term, sustainable healthcare system?
That's a great question, Dave. Let me answer it in two different parts. So first, the Netherlands and many nations in Europe have socialized healthcare, right? Their tax rate is 55%. So they figure that this is important to us as a country, and we're going to make the population pay for it.
What is the debate around it?
Right? And so they pay 55% of their taxes, of their income in taxes, and yes, they get free healthcare, but is it really free, right? So our marginal rate in the U.S. is around 28%. It's about half of that. So that means most Americans have the money that they earn in their pocket. So there's a debate to be had about that, and that's a different story. The cotton ball thing, it's a fallacy. I will tell you right now, okay? In the past, before we had insurance plans that had agreements and contracts, hospitals were paid on what was called charges. So hospital charge master was what listed every procedure, every pill, every drop of IV fluid that was given, and it had a cost associated with it. Plans said, okay, we're going to pay you a percentage of your costs. That was the way the model was evolving. And so hospitals said, well, if you're going to pay us a percentage of what it costs us, we need to say it cost us more just to capture 80% of what it costs us. So you saw these numbers on bills that showed a cotton ball was whatever, or a Tylenol pill was whatever. No one gets paid that. Because what happens is you get paid for the visit in a lump sum from the insurance company because that's how the contracts are. So that, unlike a $300 toilet seat at NASA, let's say, right? It's a pure fallacy that there's a $100 cotton ball. It doesn't exist. But what it reflects is a broken system. Our third-party payer system is simply broken, okay? More of our healthcare dollars line the pockets of insurance company shareholders and insurance company executives than they do anybody else in healthcare, right? Just to process, just as an example, just to process a claim, the average practice pays between 6 to 9% of what they earn to process a claim. Now think about that. So that's an added cost that's simply kind of a middleman fee that we built into our healthcare system because we have a third-party payer model. And because we have a third-party payer model, we've seen runaway costs. And each year, it's a competition between the healthcare providers and the healthcare insurers as to who can get the better deal, with the healthcare insurers holding all the cards. So it's very challenging. The average margin in New York State for a hospital is negative 2%, which means that if it weren't for our philanthropy, non-operating income, and for state funding, most hospitals would close their doors after a few years. How long can you operate at a negative 2% margin, right? So hospitals are stuck with the charge masters that we built. That should be redesigned, certainly. Our third-party payer system needs to be looked at. Obama did try to fix that under the Affordable Care Act with a 3% cap on, and the insurance companies found loopholes on that. I'll give you an example. You've heard of United, you've heard of Optum. Optum is an offshoot of United that they use to funnel money into so that they can keep down their earnings to 3%. And now Optum gets all the profits because they do other things for them. So they found loopholes. So the challenge is really finding a way to stabilize and standardize the way healthcare premiums are set, the way healthcare premiums are delivered for healthcare itself, and to really put a true cap on the margins of the insurers.
Just want to go back. Oh, go ahead, Dr. Clare.
Just say that's Optum, not Optimum.
Yeah.
Just making that clear for everybody.
I just wanted to go
I'll mention
back,
one thing, though, about that I think we have something very good here in our health. We've heard a lot of negatives, but I will tell you that in a lot of the countries where there's socialized medicine, if you want an MRI, you get put on a wait list. And I know people that have come to the United States, traveled to the United States, paid out of pocket to get an MRI from Canada or from other places because they cannot get it, even though they have a very legitimate medical indication to get that MRI. And that's just an example. So I think we hear a lot of negative things about our healthcare system, but I will tell you that I do think the United States healthcare system is still the best in the entire world.
I just want to go back a bit to Brian, more about the uninsured. So we all know that health insurance provides peace of mind, it provides security, but it's also necessary if you do have a serious illness. So I just want to talk a little bit about how companies like Island Harvest and other nonprofits really help those who are uninsured or underinsured get coverage, whether it's preventative care or other coverage.
Yes. So let me say that we feel healthy food is healthcare. And that's a priority of ours. It hasn't always been that way in the food bank world. Getting a meal was the priority, but now it's focusing on healthy, nutritious meals, fresh produce. And we also look at it that we're not going to solve hunger one can at a time. It's really providing more of a holistic approach, and that's why Randy Shubin-Dresner has been, our CEO, has been innovative in developing programs like our Nutrition Pathways program, where we're embedded within 6 hospital clinics throughout Long Island, where if somebody is evaluated as food insecure, they get referred to our nutritionists that are embedded within that clinic, and then they go through a 12-week program of discussing and learning about the impact of the food they eat and their health ailments, and providing them food as well on top of that as an incentive in healthy food. So we really take it as important and feel we're a bridge to a healthier life, and we're working with partners to do that in the healthcare community. We also have a workforce development program where we're working with many businesses throughout Long Island. Our focus is attached to our mission. It's warehousing and inventory control. We have a 20,000 square foot warehouse that we're moving product in and out every day. So we've developed this program and trained people with the forklift certifications. They get about 10 various certifications, OSHA, food safety trainings, and it's providing them the tools to go out and get a job and become self-sufficient. And we feel that's the way we're going to solve issues of hunger as well as affordability of health insurance, and making sure they get, not just a part-time job, but a full-time career. We really want to focus on them getting careers, and we're eventually going to get into a commercial kitchen with which we'll train people to work in the culinary programs, as well as repacking. So we're taking a holistic approach and working with many partners. We're also part of the 1115 waiver program, working with Healy and the Health and Welfare Council, which is basically focused on an individual who has Medicaid funding and attached, they come to us, they're food insecure, and we provide them healthy food. So really making sure that their children and everybody's getting a healthy meal.
Speaking of food, it's almost the lunch hour. Any other questions? Any other questions from the audience or the press? In the back, we got one in the back, and then go ahead.
I just have a question going back to herd immunity. As some of you know, my son and daughter were born at South Nassau, so thank you guys. You did a great job. But my son is 10 months at the time of the measles outbreak, and we decided to get him vaccinated early. My dad also travels internationally. He's in his 60s. So at what point, he was vaccinated, obviously, as a baby to go into school. At what point do you have to get revaccinated or a booster? And at that age, is it okay for them to get MMR again, or?
Sure. So very, very important questions. So I don't want to get too technical, but just to specifically answer your question, we don't count the first dose of measles vaccination before 1 year of life, and that's because they still may have mommy's wonderful antibody, and they may not develop a good response to the measles vaccine. However, we recommend that they get a dose if they're going to an area or if there's an outbreak in your area after 6 months. So between 6 and 12 months, we recommend in a high-risk situation that the child get vaccinated, but that can't count for one of the two necessary vaccinations. I had a grandchild that was in that exact situation. We had to vaccinate the grandchild at 8 months, and then we had to then vaccinate the child when they hit 1 year, and then at some point afterwards to get that second dose. So yeah, that's a classical example where we had to do something that's not ideal because of the surrounding lack of herd immunity, because the child could get measles and it could be a very serious disease in young children. So that's to specifically answer your question. In general, there is no need for anybody who's been vaccinated, who's gotten the 2 measles vaccinations, to get tested and to go and get an additional dose. There are those that suggest that if that person who got vaccinated 60 years ago is going into a high-risk area, maybe they might need an extra dose. That's never been adequately proven or is shown to be needed. And I don't routinely make that recommendation. If somebody has had underlying medical conditions that may have negated their ability to still have vaccine protection, such as they had a bone marrow transplant, if they have other serious illnesses, that would be a different story. But healthy 60-year-old, tell him to go enjoy his trip. And mazel tov on the babies.
I just kind of wanted to piggyback off of vaccinations and herd immunity. So as far as places like Mount Sinai, how do we get back to for example, young parents coming in and not even having a second thought about these vaccinations? Nowadays, you can go on the internet, read any kind of articles, lots of misinformation. So what can hospitals do to get back to trust in them, trust in these vaccines that are going to save lives and are going to get us back to this herd immunity where we're not seeing these measles outbreaks and things like that?
That's also a great question. So hospitals can do a lot of things. The first and foremost is outreach, education, making sure that misinformation is cut off as much as possible. So the $100 cotton ball is misinformation, right? We need to cut that off. The only way you can do that is to educate. And then the folks that you're educating have to trust what you're saying. That's the biggest challenge, is developing trust. As Joe mentioned, we've been doing this now since 2017. This is our way to educate the community at large. When these kind of conversations get picked up by the media, it gets shared with hundreds of thousands of people. Our first Truth in Medicine poll, we had a third party monitor how many views it got, 120 million views for that first poll. So we said, wow, how are we going to beat that, right? So I don't think we ever matched that again. It was just luck of the draw on that one, on that topic. But if you can reach people, then you can educate people. The second thing we can do is make sure that people have access to care. And once you have access to care, you develop a relationship with your care provider. And hopefully that care provider can engender trust in the relationship so that you will follow the recommendations based upon the science and not the popularism that we're seeing today, right? And then the third thing we can do is simply just make sure that people have the availability of all the treatments, so that we don't restrict treatments based upon who's not paying for it or who you follow, right? So the FDA said, okay, you can only get it for this. Unfortunately, the governor said, no, we're going to call an emergency crisis, and we're going to provide the vaccine for anyone who wants it. And they're requiring insurers to pay for it. So that would have been a gap, but now we're able to address that gap. And so the way we do that is I participate, as well as many at Mount Sinai Health System, with trade groups, hospital associations that help lobby the electeds to make them understand what we're trying to do and what we're trying to accomplish to keep healthy.
I just did one thing to that excellent response. I think we have to lower the rhetoric. I think the idea that it's vaxxers and it's anti-vaxxers is just not good for society. And what I think we have is you have probably the largest group of people that are very responsive to following their physician's advice and will take whatever vaccines their physician recommends. And that's still the vast majority of people. You have a small, albeit very vocal group that will not do that no matter what. They are just totally against vaccination. And I don't think we'll ever be able to convince them otherwise. What I like to do is focus on the group that I call vaccine hesitant, which is a significant, probably 15, 20% of the population that makes the difference between us having good herd immunity and not. And that group has legitimate questions. They've read stuff on social media. They have seen facts that just are simply not evidence-based. And I think with that group, there has to be a conversation. It has to be a conversation that isn't you must do this or else you're a bad person. But it has to be an explanation. These are the facts as we know them. There is zero evidence to support a link with autism and vaccines. Hundreds of studies. That information needs to be gotten out there. People will have questions about it. We have to, as physicians, we have to, as public health, be able to answer those questions calmly, politely, appropriately, and ultimately the patient has to make that decision. That vaccine hesitant group, we can sometimes get them to vaccinate against measles, mumps, and rubella, even though I may not be able to get them to take the HPV vaccine. And we take what gains we can get, we take what better public health we can get, and we walk away agreeing to disagree. And as a general comment, maybe the best way to end this is we need as a society to figure out a better way to disagree with each other and still be able to go eat supper with each other.
I will agree with that. Do we have any other questions? Once, going twice. Dana, you good?
Good.
Okay, thanks everyone for coming. I believe there are refreshments.
Just like to thank again our partners, Optimum and Forley, for making this happen, and we're looking forward to doing another event later on this year. So thanks again, and there is lunch outside. Thank you.
And thanks very much to our panelists.